So I'm going to do a quick one on ventilators. Ventilators. For those who are not familiar with them, and that's actually a lot of people, surprisingly, even in healthcare, by all standards. In fact, I'm going to give you a bit of information that maybe you didn't know. If you are a person on a ventilator and you're staying at a facility, and my facility, for example, is one that the only one other than Eleanor Slater in the state that actually manages ventilator patients, and so that's two in the whole state. So if you want to talk to people who know anything about ventilators, talk to those two in the state. Otherwise, it's private homes or families or group homes. That's it, right? So if we call the EMS in the town that this facility's in, we ask them to come pick up a ventilator patient. Guess what they tell us? No. They won't manage it. They won't even handle the rest. We have to call a private company to come pick up ventilator patients who are having problems and they need to go to the hospital. Maybe they need imaging or diagnostics that we cannot provide. Town won't do it. You pay taxes. Town won't do it. Won't do it. Gonna pay an individual, a private company, to come in and do it. As far as ventilators are concerned, when people are put on ventilators, when we use that intervention, it's always, if we're looking at it overall, 40% of the time, this keeps falling, people we expect will die. The other 60% of the time they live, and the vast majority of them show some kind of improvement. We can bring them back to some quality of life. Almost 100% most of the time, and then sometimes it takes them a little bit longer. We got to wean them off, but there's unfortunate circumstances where we've utilized that intervention appropriately, but unfortunately the damage and the disease progress was beyond what we could prevent, and people will stay on it for the rest of their lives to varying degrees, and it's a very big ethical dilemma. Again, it's something most people in healthcare don't experience unless, again, you've worked in group homes, which in group homes these people were born like that, so it's a little bit different. When you go into facilities that are taking on these patients, and again, that's Eleanor Slater, one of the facility in the state, you can look it up. They're on a ventilator for the rest of their life. They can't clear their own secretions. We're sticking a tube down their throat multiple times a day to suction it out for them. They're never going to eat again. They're never going to talk. They're at varying degrees of traumatic brain injury. The whole purpose of setting up ventilator supportive options outside of a group home model or even Eleanor Slater was because, those were considered rarities. Most people improved. 60% of people who got put on a ventilator improved. We didn't realize we could keep people alive for as long as we could using ventilators like that. And the vast majority of people we were trying to support were people who were degenerative diseases. They got to a point where they couldn't do the breathing on their own anymore, and the only way they could live is if we put them on a ventilator. And many of them choose to get pulled off the ventilator and die peacefully with their family surrounding them. Because it's not pleasant. So you're talking about that's best case scenario. That's what we know it now. Well, maybe a couple months ago. So before you put a whole lot of faith in those ventilators, remember this. Under best case scenarios, 40% of people die. The other 60% have a pretty significant chance of doing well. But there's always those those few, those ones that don't meet what we acknowledge ethically as good or bad, or we don't know how to define it. It's the reality of our technology. You're looking at a disease right now where it's killing the most vulnerable, you know that. The people who already have, a lot going against them. And 90% of the people you intubate and put on a ventilator are dying. Just, read up on what it's like to be ventilated. 90% of them are dying. It's like 10% are left, which is a huge difference from our approach now, which is 60% live. And there's 10% live. How many of them already sick, not doing great, are going to end up having tubes shoved down their throat for the rest of their lives and never able to eat anything or talk or anything? You know what I mean? Just honestly, so many of us in healthcare, we want to save lives, and that's great. We want to have the answers. We want to be able to tell you, we can make you better. But you gotta remember, and trust me, talk to those of us who manage that support. When it can't work, when it doesn't work the way it's supposed to, you're bound by the decisions of the family. You're bound by the reality that you don't get to choose who lives and who dies. But oftentimes doing things that create a lot of pain and suffering too. And those of you who put that tube in, you don't have to live with that reality. They leave your hospital, guess what? EMS won't even bring them back. We have to call a private company to do that. Just remember that. Please.